Good afternoon. My name is Susie Shirley, and I'm the Director of Community Engagement and Fellowships for the Veterans Health Administration Innovation Ecosystem. Thank you all so much for joining us today. We're thrilled to be hosting the Breaking Boundaries Using Innovation to Advance Health Equity panel for VHA Innovation Experience. The COVID-19 pandemic has brought social and racial injustice and inequity to the forefront of public health. COVID has disproportionately affected many racial and ethnic minorities, putting these communities at greater risk of complications, hospitalizations, and mortality. Despite these challenges, stakeholders like yourselves are working together to ensure that equity are integrated across public health efforts so that all communities will be stronger, safer, and more resilient. From policymakers working on social change to clinicians finding tailored solutions for their patients, we know that these collaborative innovations can help us get closer to a society where everybody can live longer, healthier lives. Over the last several years, we have seen the effects of the digital divide on health in low-income and marginalized communities, elderly patients, and those living in rural communities. And in searching for solutions, we know that there's not a single solution that will eliminate health disparities. Instead, we need to think of access to innovative healthcare as a fundamental right. We all play a role in helping to promote fair and equitable access to health. And to do this, we have to work together to ensure that people have resources to maintain and manage their physical and mental health in ways that fit the communities where people live, learn, work, and play. We hope that the ideas that come from this panel today will serve as a catalyst for future progress. Thank you again for joining the conversation today. And now I will turn it over to my friend and colleague and the moderator of our session today, Dr. Ernest Moy, Executive Director of the Office of Health Equity at the Veterans Health Administration.
Thank you so much, Susie. And I am totally delighted to be here moderating this panel, Using Innovation to Advance Health Equity. As Susie indicated, I am the Executive Director of an office whose focus is on health equity. Our goal is to make sure every veteran gets the support he or she needs to maximize their health. And this is a very, very complicated task. I'm going to tell you a little bit about myself. So I have studied health equity for my entire career. I'm a general internist by training, and I've worked in academia, the not-for-profit sector, but in the federal service for the past 20 years. For much of that time, I was with the Agency for Healthcare Research and Quality and then the Centers for Disease Control, studying health inequities. And I came to the VA 3 years ago because the VA has the services and the facilities and the providers needed to actually fix some of these problems. And here at VA, that's what we're trying to do. One of the best assets that we have is our innovations ecosystem. This ecosystem allows the best in innovations to be brought to the fore to improve quality and care for veterans, but also to reduce inequities. And I'm delighted to be joined by so many experts in innovation today. I'm going to turn it over to them to introduce themselves. So with that, can I ask you to introduce yourself, Jay?
Sure. Thank you so much, Dr. Moy. And it's just a privilege and honor to be with this group of colleagues and to talk about a really important issue. I'm the son of two South Asian immigrants. My dad, a pharmacist on the south side of Chicago, and my mom, factory worker, and who saw firsthand the challenges that vulnerable communities faced. And that's inspired me to be a public health physician and physician executive that's been working at the intersection of public health and healthcare delivery, but also driving forward innovation with an equity lens. And I currently am a primary care physician, a geriatrician, and work as the chief clinical product officer for Medical Home Network, which is a Medicaid ACO, and More Care, a Medicare Advantage health plan focused on the special needs population, as well as working with ABC News. And so just delighted to be in this conversation with you all today.
Thanks. Freddie, can I ask you to go next?
Sure. Thank you so much again for inviting me to be part of this panel. My name is Freddie Wynn. I have really lived initially in France, but really all over the United States and Texas and Arkansas and Illinois, Massachusetts and New York. And so I've gotten to see a very wide breadth of different patient populations over the years as well. So I'm actually a medical resident in the pathology department at Mount Sinai Hospital in New York, and also a research fellow at MIT in Boston, and have been formerly a co-director for a group called MIT Hacking Medicine that has really led a lot of innovative new technologies and new ideas for healthcare. More recently, have pivoted a lot of our efforts using healthcare hackathons from MIT Hacking Medicine into launching the MIT COVID-19 Challenge, which we partner with the VA on. And then more recently as well, launching the MIT Hacking Racism Challenge, where we hope to address some of these issues facing health equities, but trying to use some of the same guiding principles that we've used in terms of accelerating the innovation process within the healthcare space.
Thanks. And Stephen?
Thanks so much, Dr. Moy. It is an honor to be, I think, the only non-doctor on this panel today, but surrounded by some of the smartest people I know in the health equity field. I'm Steve Schwab. I'm CEO of the Elizabeth Dole Foundation. We focus on health disparities among military and veteran families. Specifically, we focus on the support and service needs of the nation's millions of military and veteran caregivers, either the spouses, siblings, and other loved ones who are tending to veterans and wounded warriors in homes all across America. Health equity is a really important subject for us at the foundation as we look across the diverse veteran and military population. We know there are equity issues and disparity issues common in the military and veteran issue to the civilian population. And I'm really looking forward to talking about and learning more about health equity in general in today's panel.
Thank you, Stephen. And Lisa?
Thank you, Dr. Moy, or Ernie, as I've known you for a number of years, as we both had the privilege of working together at the Agency for Healthcare Research and Quality. So my name is Dr. Lisa Simpson. Yes, I am another one of the physicians on this panel. I am a pediatrician by training. And since we've heard a little bit about our respective geographic histories, I actually grew up overseas as the daughter of a foreign service officer. So not a military brat, but a diplomatic brat in other settings, and did my pediatric training in Hawaii, where our populations that experienced a lot of health disparities were actually the Native Hawaiian population. And so had experiences working in federally qualified health centers in care for Native Hawaiians. So I think that was my first real exposure to the reality of health disparities. I am the president and CEO of Academy Health, and we are the national organization for health services research, which is really the type of research that has generated what we know about disparities today, has led to the documentation, the sort of putting a spotlight on how, when, and where disparities occur among all populations, including veteran populations. And there are many researchers in our field who work at the VA and with the VA. And I want to echo Ernie's point about the opportunity in the VA to actually address equity through so many different tools available to them, because I have an impatience as the leader of this organization to do what our mission calls on us to do, which is to improve health and healthcare for all by advancing evidence into policy and practice. So just knowing what the issues are is not enough. We must do. And I really look forward to this conversation with all of you.
Thank you so much, Lisa. So I'm just going to go ahead and get us started. So we have some questions that we want to address today, but probably the place to start is, what is health equity? What does it mean? And what can we do to advance it? Why is this important? And I was going to start with you, Jay. Could you start with that question?
Sure. Thanks so much, Dr. Moy. And I would define health equity as everyone getting the support they need, which may be different, but that can produce the same outcomes. And that goes for health. And I think the important thing I think about in this is language. When I was Chief Medical Officer at the American Hospital Association and leading our equity work there, one of the conversations we had across the country is where you intervene makes a difference and how you define it makes a difference. So when we talk about social needs, helping individuals have access or get connected social needs, whether it be housing, food security, or transportation, is one part. And then when we go to the influences in the socioeconomic environment. That's, for example, if we take the housing issue, lack of affordable housing in a community. And then the health equity or systemic or structural issue is the policies that have impacted zoning or have created discrimination or have created unequal playing field for accessing affordable housing and having it in the community. And so, I think where you intervene along that continuum makes a difference, and there's overlaps as well. So I think I would sum it up by saying it's not only about the gaps that exist that need to be closed, but it's also about creating opportunity for equity in communities.
I'll let anyone else want to chime in on what is health equity, why is it important?
If I could just follow up on Jay's great points and excellent definition of health equity. One of the things we found at the Dole Foundation is that health equity manifests itself in diverse ways, depending on the population you're talking about, right? And we know, for instance, in the military population that we're focused on, particularly today, that we're seeing increasingly numbers of diverse folks entering military service, thus becoming veterans, right? Our younger veterans are more diverse in terms of where they come from and their socioeconomic backgrounds, which means their families and the folks that take care of them at home are more diverse. That means that we're seeing a lot of, for us at the Dole Foundation and with a lot of the organizations we work with, a lot of access issues. Susie, in her opening remarks, I think talked about the digital divide. We're still working in a lot of parts of this country to get folks access to the internet. And that might be something that people forget, but there's still pretty big swaths of this country, particularly in the veteran and military population in rural areas, where folks don't have access to information. And at a time when a pandemic means that you're accessing healthcare largely through virtual means, the way that we're doing this panel today means that there's still a lot of people in this country who don't have access, the access we take for granted, to medical, emotional, mental health support, which has been so important during this pandemic. Last thing I'll just add, as Jay brought it up as well, is this pandemic has brought about a sea change in terms of the disposition that people have on accessing healthcare. We're more willing to talk to our doctors, our nurses, our social workers, even our PTs in a virtual format, which for us, we've seen surging amounts of people accessing care, which is really, really good news. But that also means that we have to meet that gap on the digital side to make sure that there are equity rates among still a large part of the population that don't have access.
If I could just add that to both Steve and Jay's comments, is that the importance of there's no one definition of equity, because it's very much through the eyes of the individual experiencing the challenge, the health challenge, or the community, the population that is being served. And so I think we have to be okay with the complexity of that definition and its evolution. Also, as we learn more and more about what is achievable to have optimal health and well-being, I think we want to keep moving that bar further along and push ourselves to not just have equitable, measurable physical outcomes, but Steve, you mentioned mental well-being, physical functioning, getting back to, what is it if you want to be a basketball player? That's what we want to achieve, not just walking. And so I think there are multiple dimensions of equity, and the patient voice is critical to all of them in the VA and everywhere else.
I'm just going to briefly add too is that, most people are often used to looking at equity through just a few lenses, as has been mentioned, whether that's been race, ethnicity, or gender. But to the point of everything from socioeconomic to the local environment plays an impact in that. And I think what makes things even more challenging in this space is it becomes less and less feasible to essentially be able to bucket populations and to be able to say, how do we address health equity for this particular population? Because now if you start thinking about how each individual is really at the intersection of multiple of these verticals that we tend to use to classify individuals in terms of trying to address the health equity work. And so I think, trying to get at a balance between how do we treat this as a public health or population health type of issue versus really an individual health or personalized medicine type of issue.
Thanks. I think the current pandemic has certainly caused a lot of disruption in our entire healthcare system. I think it's also made us rethink our value towards health and healthcare in a lot of new ways. And this creates new opportunities maybe for doing new things. I was going to ask you, Lisa, how do you see innovation helping to advance health equity? What are the areas where we have need and where innovations could fill that gap?
Yeah, I actually, well, first of all, where do we have needs? Everywhere. Basically, anywhere you look, you're going to find an opportunity for advancing equity. And that's, that is the sad state of our care today. I think I have yet to find an area where some dimension, to Freddie's point about intersectionality, some dimension of where equity can be better achieved. I do want to come back, though, to the point sort of innovation to advance equity. I want to make sure that when I think about it, it's all innovation should be seen through an equity lens. And we need some innovations to tackle inequitable outcomes. So even where we may not have documentation, we need to have that kind of specificity of achieving equitable care and seeing it through the equity lens. So I think it's a both and. In terms of specific areas where I think innovation can help us, there are some specific areas, and I'll let Jay and the other experts here talk about, certainly Steve, with your experience with caregivers and families, specific needs. Some that I would point out is certainly mental behavioral health. I think that is because of the issues of historical stigma on top of, other factors that contribute to inequity and racism, structural racism, bias, social determinants, the ones Jay mentioned. There's also the added stigma that is so dominant for so many in mental behavioral health. So that's one area where I think innovation could really help. The other one is sort of not one sort of vertical targeted domain of care, but it's an underlying feature of care, and that I think the pandemic has really emphasized, and that's trust. And so we've got a good evidence base, pretty robust around what we know and understand about what builds trust or breaks trust between a patient and a clinician. And we have some sense of what between communities, historically excluded communities, usually communities of color, disenfranchised communities, their trust with organizations, healthcare organizations. But we know some there, not a lot. And then we don't know, particularly during this pandemic and the burnout that so many healthcare providers are experiencing in the VA and elsewhere, of trust between the healthcare provider and the institution. And so I think this underlying, nothing else is possible in terms of care planning, care delivery, unless there is trust in those relationships, because care is, a therapeutic alliance. It's a relationship with a family, a patient, and between an organization and community. And we've just launched an initiative in partnership with the American Board of Internal Medicine Foundation, where they're focused on building trust generally. And we at Academy Health are working on helping to build that evidence base, not to document where trust is a problem, that's important, but really what organizational interventions, community-based interventions work to build trust. Because I think we've really seen the impact of lack of trust in institutions during the pandemic and the lack of vaccine acceptance in some communities. So that may not be your typical domain that you would hear about, but I think it's an important dimension of the equity solution.
Lisa, thank you so much for mentioning stigma and trust. Big part of our work at the Dole Foundation that we've been doing in partnership with the VA is to push against exactly those two really big obstacles in delivering health equitably across the military and veteran populations. We have a campaign that we started called the Campaign for Inclusive Care. It's happening across 3 VA VISNs right now. For folks listening, VA VISNs are essentially regions of the country where VA delivers care. We're training doctors, nurses, social workers, and frontline medical personnel on clinicians on how to engage in healthy, equitable dialogue with patients to increase trust. Dr. Simpson, we're seeing astronomical data on levels of trust increasing between clinicians and family members in a care environment, frankly, where a lot of care delivery and conversations happen between clinicians and veterans one-on-one, where care is moving, and you all are clinicians, so you know this, to a family affair, especially in veteran and military medicine, where families are involved in the healthcare recovery and rehabilitation of veterans. So this campaign, which the VA has embraced really holistically, is encouraging those clinicians to widen the dialogue and engage wider numbers of families to increase trust and to defeat stigma. So we're seeing increasing levels of healthcare utilization across the board, across demographics. We're seeing trust increase across demographics. We're seeing families who are encouraging their veterans, no matter where they live or where they come from, to rely on VA care, to access VA care, and to follow up on their clinicians' instructions. That's an innovation, I think, and Dr. Simpson, I'd love to talk to you about that program in the civilian setting, given the work that you and your organization do, because we think there are a lot of parallels in the civilian sector. The thing that's great about VA, and I want to encourage every VA clinician who's listening to this panel today, VA is uniquely positioned to address health equity, unlike any other healthcare organization in the country, right? Disparities are complex. We've said that health equity is complex and the definitions are diverse. Well, not many medical organizations offer benefits and programs around education, homelessness, housing, in the ways that VA does. And so I think clinicians at the VA are uniquely empowered, can be unique, certainly uniquely positioned and empowered to push against those health disparities, to encourage health equity inside of an organization that uniquely addresses those kinds of gaps.
So I would just echo Dr. Simpson and Steve's comments. I think they're well said, and say that part of the secret sauce, I think, for health equity is the issue of trust. It's awareness and understanding, and trying to help people get a real grasp of the issues, and then lived experience. I think innovation powered with human-centered design, enabled by technology with process and people, I think, have the greatest impact on trying to move the needle. And one of the things we saw, is that with the medical home network or routine care Medicaid population, it can be hard for the folks impacted by the pandemic that are experiencing social, economic, or environmental challenges to access the care they need, the understanding they need. And so we created, using our COVID-19 Vulnerability Index, an AI-enabled predictive model that helps prioritize care management outreach to patients most at risk from the virus. And then taking it a step further, identifying what we refer to as the socially isolated or people without support systems, so our care teams can proactively educate and offer assistance to people in regards to COVID-19. And it also includes the support we give caregivers and enabling caregivers, and include physicians, but also family members of veterans and their friends that support them. I think that support system becomes so important, and trust is an anchor of that. Information is an anchor of that. Understanding what kinds of supports can make the most difference. And so people are cognitively, functionally, and socially worse off in some ways from the pandemic. And so it's also understanding where they are in their kind of health journey, to help them, to the point I made earlier, where get the supports they need, which may be different, and just simply also asking questions of observations that are made about why there are differences in some populations or environments than others.
I'm glad that Lisa brought up the point of trust that everyone's really spoken to already, but really what's underlying that is not simply what's on the patient side or on the community side. We really need to take an inward look towards ourselves, towards our own systems, and what's underlying structurally in the healthcare system that's causing that, right? If we're looking at even the diversification of our clinical workforce, which still needs a lot of improvement, and that's part of building that trust with the patient population, right? If they don't see or identify with people of their own community who are treating them and who are providing their care, that's a barrier that is sometimes unsurmountable, especially if you are in a more rural area where you don't have as easy access to care. And so I think that component also needs to be looked at in addition to the awareness of people that have about, inherent bias or subconscious bias that we may not have in terms of how we're treating people and others as well.
Ernie, there was one other area that I think VA is uniquely able to work in innovation, and that is there are some innovations that are developed in one care setting, one VISN, one community, and the data are good, they look successful. And the question is, can VA then scale and spread them? And so that sort of innovation around scale and spread, adaptation, fidelity, all the nuances that go into that. You can't just take something and plop it in a different community or a different patient population. But that transition from single or two-site innovation to major impact, I think VA really has increasingly done that, and I think has a unique opportunity. And then there's the innovation, which is just, we don't know what to do for this challenge. And that's more the very developmental, human-centered design driven, develop something new. Yes, informed by the evidence, but try something out of the box. And so I think we need both. Take what we know works and the evidence of that effectiveness and scale and spread and develop new interventions.
Yeah, and I think I would just add to what Dr. Simpson said is that in the context of a learning health system, which I think the VA is well positioned about, how are we learning from the implementation and then quickly, pivoting and getting to scale because of that learning. And I think the query system, all the programs that are in the VA are just, I think, wonderful to help do that.
Yeah, I love this conversation about trust. There's so much lack of trust out there about information in the healthcare system. And so very, very early on in the pandemic, we talked to our veterans and say, okay, what can we do to make sure we get you the right information and that you can actually implement it? And trust was the biggest thing. And we talked about trusted providers. The other special sauce I think we have in the VA is veterans trust other veterans. And when we can get them all lined up to help each other and get the information they need and be able to implement it, that really makes things work. But by getting someone to trust you, I think that creates a moral obligation. And so I wanted to ask Steve if you would talk about some of the moral and business implications of working with veterans to improve health equity, getting them to trust us, getting them to believe us, and doing things that change their lives.
Yeah, Dr. Moy, let me say one thing before I go into that question on a point you just made really importantly. The veteran population, as I said earlier, is increasingly diverse. And for those of us who work in the military and veteran space, and honored to do so, we have to remember that that diversity is rich. So when we're putting ambassadors or advocates or folks who are sharing information out there, it's important not just to put veterans out there. It's important to put folks who look like the folks, who know the folks, who've lived with the folks, with the veterans, with the military populations that you want to speak to. It's not a homogeneous veteran population, in other words. We've learned that really importantly in the 160 communities that we work in at the Dole Foundation. On your really important question around a moral and business obligation to invest in health equity, a quick answer is yes. If you consider just quickly that less than 1% of our population serves, and then you consider the socioeconomic demographics that we've talked about of those who serve, you can't ignore our moral obligation to advance health equity for any veteran serving organization like VA, or for civilian medical organizations, many of whom support this population in communities all across America. So investments, I think, need to be made in other factors that we spoke about earlier: safe and affordable quality housing, access to nutritionally dense and affordable foods. We haven't talked a lot about yet in this panel food issues, but there are a lot of nutritional and food access issues in the military and veteran population right now. They're particularly acute during the pandemic. And we've seen communities, especially community food cupboards, stand up in really incredible ways to push against those food equity and health equity issues in their home communities. That has made a huge difference. There's potentially the more challenging issues around recognizing and understanding how social factors like racial, ethnic, gender, sexual preferences, and poverty have also perpetuated inequities. So in short, I guess continued investments towards these initiatives and programs, I think, are critical for supporting veterans and military populations, but it's also important that we, the VA in particular, and MilVet nonprofits like the Dole Foundation, we need to conduct intentional outreach, diverse outreach, like I said at the top, outreach with populations, with ambassadors, with information deliverers, not from under, our plain Twitter accounts, but finding folks who can reach out and engage these populations in ways that are unique to where they are, who they are, where they live, and that we can extend our support, our offerings, our medical access with and through trusted partners in those particular communities, partners that they trust. We keep coming back to this trust issue, which I think is so important.
I think, Steve, you said, I think the important issue of also the economic cost of inaction and the consequences of that. Nearly 200 billion is impacted by health inequities, and so that has real consequences. And people that are able to access things with equity, you have reduced medical costs, you may have reduced disability costs, you can have an impact on the workforce, caregiver burden. I think there's a lot of those components that then make an impact. So it is not only the right thing to do, it's a smart thing to do.
Yeah, and I certainly see that playing out in much of the work that we do. So, often the VA will try to improve quality for the entire population, which I think is a wonderful and laudable goal, except for many of the things that we track, it's not, that everybody is doing poorly. There's some groups that are doing poorly and some groups that are doing well. And I think there is efficiency to be gained by focusing quality improvement to help those who are doing worse. And if they're in a particular population group, there may be commonalities in their environments and their exposures and access barriers that make it more efficient, again, to treat them as a group as opposed to trying to improve quality for everybody, which is what traditionally VA has done.
To your point, Ernie, I just want to emphasize the importance of data and the ability of the VA to collect that data. And Dr. Moy led the development of the first National Healthcare Quality and Disparities reports when at the agency I was at. And if you look at those reports over time, each year they've been published, you see those metrics for which and they're reported by disparity as well. You see that, we're improving on some metrics, far fewer than I would like as a nation. And we're getting worse on some in terms of the disparity, and we're just stagnating on others. And so, we have to use that data to drive our investments because otherwise, the reality is we have limited time and people, and we're in a pandemic right now. And so we really have to, as the saying goes, sort of put your money where your mouth is and make those targeted investments. And we're a small organization at Academy Health, but we made a commitment last year with our board of directors to really increase our commitments to the dimensions of equity that exist in our field. And that's a lot about the diversity of researchers and to increase the representation, to elevate the voices, to amplify the voices of more diverse researchers in all of our settings, as well as several other activities. But I think it gets back to your point, Dr. Moy, about the moral obligation. I mean, if we are truly to improve healthcare for all, we can't ignore those who have so much more that needs to be gained to achieve that optimal health. And it's the quote on the Department of Health and Human Services, about the dawn of life. Of course, I'm misquoting it, but I do think we have that moral obligation.
Yeah, and actually, I'll throw in that the motto of my particular office, the Office of Health Equity, is leave no veteran behind. Because when we don't deliver the best possible care and support to all of our veterans, someone's going to get left behind. And that's inconsistent with health equity, quality improvement, high reliability, all the things that we say that we tout. We cannot permit disparities to continue. So I'm going to shift a little bit over to you, Freddie. So I think of you as our approaches expert. So what approaches to innovation do you think would be successful for helping to improve health disparities?
So, I mean, obviously that's a huge problem to try and tackle, but in terms of the innovative types of approaches that we've used in the past to tackle complex and hard problems, on which there are plenty of in healthcare, outside of health equity, along with health equity layered on top of it, has really been trying to bring people and build communities of people who are really coming together to solve these problems. And we've done this through, whether it's been our healthcare hackathons or through joint events with different partners, but really with every challenge that we've had has been about bringing the ecosystem together, bringing all of the stakeholders together, not simply in the development of the solution or trying to figure out the right solution, but at the very beginning, when you're even thinking about what is that problem and how do you define that problem? How do you scope out that problem? What's that problem look like from the patient perspective, from the clinician perspective, from the family caregiver, from the payer, from whoever's actually going to build the solution? And to us, that's one way to help accelerate that innovation piece, is that instead of developing within a couple of silos of our respective institutions, organizations, is how do we come all together from the very beginning to really develop those solutions. And I think we've done that fairly successfully with the number of network of partners that we've had over the years, working with MIT through these types of challenges. But it's also coming to realization that, we each may know a lot, but we don't know everything, right? So getting to understanding that the different frameworks and different perspectives from not just other stakeholders, but even people outside of the healthcare space altogether. Are there lessons that can be learned from other sectors? Are there lessons that can be learned from even outside the United States that can be brought into our system as well? And so that's really been our approach to really sort of democratize the innovation process and really build these community of innovators throughout the globe, which, when we looked at, for example, when we launched the MIT COVID-19 Challenge last year, we had thousands and thousands of individuals from all over the globe, from literally over 100 different countries that came together to tackle these problems. There's no reason that we can't get that same kind of mass appeal and community towards health equity issues. But the added impact too is that with equity is that it's a lot of the underlying issues aren't unique to just healthcare. I mean, a lot of the underlying issues stem from whether it's the inequity in education, inequity in jobs, inequity in housing, that are all interrelated. And so this is definitely one of the topics that we can't just stay within our own silo to begin with. I think the second aspect, in addition to sort of the multi-stakeholder approach, is really the appeal to, what we often say is pivot, fail fast and pivot. Essentially that we should be trying any plausible ideas on a small scale, seeing if it works, seeing if it has any traction, and trying to continue to iterate and optimize continuously with continuous feedback from those various stakeholders. Because I think without that, we often will stay stuck in our respective silo or stuck in our stage thinking that, oh, if I could only get this one more piece of data to really tell me that this is what's wrong with the problem, or if I can talk to that one more group of patients to be able to validate what I'm thinking about. I think we often get stuck in those roads as well.
So Lisa, you must have a notion of health services research and best approaches.
So, there's a robust literature on this. And I think one of the questions, I don't have a simple checklist of, this. And so I really appreciated Freddie's description. And I'd like to kind of add to that, if I may, which is what are the characteristics of successful innovations or successful interventions in general, and also in equity. And one is what you mentioned, the partnered solutions, partnering with the community, the patient population, caregivers, et cetera, to truly understand the needs. So you're designing for the right challenge. The second is the leadership commitment. And that is absolutely critical if these, rapid fail fast and learn and adapt and then get ready. there's got to be sustained leadership commitment to then taking that and actually deploying it at scale. And then I think the other thing, particularly in healthcare, that we talk a lot about and is perhaps maybe less relevant for the VA, or I don't understand how it plays out in the VA, but it's the sustainability. Like, who's going to pay for this? Like, what is the business model for this innovation? Does it save money? Gets back to J-Bot of, doing the right thing and doing the smart thing. And so thinking about that from the beginning of how this is going to be sustained if it is found to be effective. So I think that upfront thinking about the business model, because also for innovations that are tech or otherwise oriented, most solution developers, while the VA is a huge market, it's not the whole world, and they'd love, you've got to be able to prove it in lots of different settings. So I mentioned sort of those, the payment and business model, the leadership, and the partnership are three I would pull out from what we've learned about successful innovations. And then the final one is attention to the organizational culture. And, because in the end, it is staff and leaders and middle management and clinicians who are going to be implementing and sustaining whatever innovation you bring, let alone the partnership from the patients and their families. So really attention to that change management, that literature on organizational behavior, I think is really important these days.
Oh, I would just echo those comments by both Freddie and Lisa, and just also say that I think there's an important moment here to say, how do we rethink public-private partnerships? I mean, we've learned so much when it comes to vaccines, treatments, PPE and manufacturing, and digital, but also how do we help those that were essential workers on the front lines and the inequities that they may have faced. But I think there's a lot to say, how does the VA work with also the private sector even more efficiently and effectively than they have? I think there's been a lot of good work that the VA has done. And so I think that the components that Freddie and Lisa talked about are important to that. And I also think that the pandemic's inspired unprecedented interest in artificial augmented intelligence to think about use in the issues of equity and innovation. And we know that it can be a force for good and help contribute solutions to some of society's most pressing issues, such as the one we're talking about today. But however, to accomplish that, we must ensure that those systems have trustworthy and ethical parameters built in from the start. And that also is driven, from the lived experience and having an approach by where you filter and test some of what you're building to see, if it's causing unintended consequences. So I think that's an important question also that organizations and teams have to ask.
Dr. Moore, if I could just add at the end here, because I think this is fascinating, all the comments that have been made so far. At the very fundamental level, what we've learned at the Dole Foundation, I mentioned we're working in 160 communities across the country. We're engaging with mayors and county supervisors and heads of VA and in these communities that we've formed and these working groups that we've formed. What we found pretty much at the outset in every community is a lack of research and data, fundamental research and data to understand the health complexities, the disparities across and among their populations, and really zero to little understanding on the disparities in the military and veteran populations. So we've had to step way back. We've invested millions of dollars, and I mean millions of dollars at the Dole Foundation in evidence-based research, new research, so that we can give these frontline mayors, community leaders, civic health leaders, community foundations, and philanthropists all around the country a research roadmap to understand disparities and inequities in their particular communities so that they can make intervention decisions based on data, right? Sounds pretty elementary, but when we discovered this big caregiving issue inside the military and veteran population 20 years ago, when we started the Dole Foundation 10 years later, I came on and said, we're not going to create our interventions unless we know what the data tells us, right? So we've just commissioned a huge study from RAND to better understand the disparities in and among 160 communities around the country. And we're working with the VA. Dr. Moy, we could use your help, Susie's help, and others, but we've got the Secretary's cooperation to be better at giving data to community leaders across the country arming them with the kinds of information that they need to know how to support the disparities in and among their populations.
I just did want to echo a couple points. One, especially when Jay talked about private and public partnerships and the opportunities there. But I think the other way to also cast this is, what we've always seen as top-down innovation versus bottoms-up innovation. And we really have to develop the community in the pipeline to allow good ideas to really come from anywhere, whether that's the frontline worker, whether that's from the patient themselves. We have to have that environment for people to want to innovate, not just wait for the leadership to create that, because that's how any of our startups come about. And I think the VA has been really great about that in terms of not just being involved with our events at the very ideation level, but having worked with a lot of early stage startups really across. And to one of the points that so brought up earlier is, one of the values of the VA is being able to not just test and value within one VA, but then be able to go to another VA and really scale across the entire VA, which we've seen them do with several other startups that have come out of MIT. And I think that's a missed opportunity if we don't take advantage, again, of people who are not within our day-to-day healthcare fields, to empower them and to give them those accesses and inroads, whether that's access to test and validate, access to data to develop their innovative ideas, and then to nurture them as part of that process. And I think the VHA's innovation ecosystem has been, I think, remarkable in that process, really tackling on every level, not just waiting until, companies in Series B or C before they even engage with the VA.
Thanks. Yeah, no, I think, one of the things that's been brought out during this pandemic is that not only do we need to work together, but we actually can do it. So part of the fourth mission of the VA is helping our public health system deal with emergencies. And so when Boston and New Orleans were getting slammed, our hospitals opened the doors and we were taking care of non-veterans and they were taking care of our folks. And really, maybe it's sad, but it takes an emergency to bring us all together. Imagine if we could all be together just to deal with these issues like health inequities that are persistent and really do require us to work together as a community to address. I want to flip one back to you, Freddie. So Susie and I have worked with the MIT hackathons in the past, working on like simple questions like how do you improve access to care, or, how do you manage rare diseases? And you mentioned that you did a hackathon that focused on racism. I just was going to ask you to say 2 minutes about, the hackathon and racism, because it just sounds like it would be so different.
It definitely was. And, to a point I mentioned earlier, trying to detangle what was purely due to health reasons in terms of health equity versus just broadly inequity issues and in terms of structural racism across the board was perhaps the most challenging part, because we kept circling around the same issues of, well, what's the access to jobs in terms of the clinical workforce? What's the access to education for people to even get to that job? And all these, predate, even the basic patient to physician relationship. And it's a bit of a chicken and egg, right? Because if you don't have, for example, people who are diverse at the leadership of an institution, trainees who are of color will not go to that institution to train. And it's a self-propagating process. But if we've not trained those individuals, how do we get the people into the leadership positions? And if those people are not there, how are kids or people who are growing up even see potential role models to enter into that workforce? And this is kind of one example. And so what we really took the approach of doing the Hacking Racism Challenge is really trying to, again, build a lot of partnerships across the entire spectrum, both within and outside of healthcare, all knowing that it has some underlying role as well within healthcare as well. So, and that's been our approach. And I think the other part has been to really try and identify early on to what we call kind of our implementation partners, right? If good ideas come out of one of our hackathons or events, or good teams come out, how do you build on that momentum to then get them plugged into either the right place to continue to test and validate their ideas and build upon it, or how do you give them the right resources in terms of mentorship and guidance to pull them in the right direction if we do have the right team pulled together. And we do that through both our network of mentors, but also through the strategic partnership that we put in place as well. And so as part of, we're doing our second iteration of this event coming up in November. And there, we're partnering with a couple of other organizations, but one is a clinical partner that's unearthing and opening up all of their internal data for participants to gain access to and to be able to problem solve with. But right after the hackathon is followed by a 3 to 6 months, or what we call an incubation period, for those teams to then embed themselves with the health system to continue to develop their ideas and to test and validate. But it's not just a simple matter of what some people call this sort of outside in innovation, right? Where you're just putting the problem out there, you're hoping somebody else solves the problem and bring it into the system. We're looking at this as a very co-developed process. So there are people within the health system on these teams, as well as people outside of the system on these teams, to work together to solve that problem, because they have, again, different perspectives that they're bringing to the table, but they're also bringing in, intangible type of information from inside that you wouldn't know unless you work within that health system or within that entity. The other part that we've done that's different from our prior hackathons has been really the focus on the pre-education component, pre-hackathon education we do. Not just on the subject matters themselves in terms of where are the health inequities happening and what's been tried, what hasn't been tried, what's worked, what hasn't worked, but also about the process, because we're now hitting on two different populations. We may have people who know a lot about health equity, but who probably have never been to a hackathon, never thought about human-centered design, or never thought about problem solving with people outside of their little bubble, so to speak. And then we have people who are obviously very passionate about problem solving within healthcare, but know very little about the complexity involved in health equities.
This sounds wonderful, Freddie. I just wanted to, draw us to a close. It's been a wonderful, wonderful conversation. And I want to give each of you 1 minute to talk about what are you going to do about health equity in your organization moving ahead. Jay, do you want to start?
Sure, thanks. It's been a wonderful conversation. Just appreciate the insight by this group. And I think wanted to start with continuing to work to advance culture and leadership. And I think that starts with recognizing our own biases and our own shortcomings, and training and developing around that so that we can be even better prepared to serve those populations experiencing inequities. Two, continuing to be on a path of a default setting where lived experience and human-centered design is part of everything we do. And we're really, focused on that, because that should really inform our approach and work. And, I think that working and thinking about intersections across sectors and how we, use data, you have partners to address some of the critical issues that we're working on. And it starts from the one-on-one conversation I have with my patients and fighting misinformation to the more systemic work we do with the county health system and the community health centers and the veterans that are in our community as well. And then I would lastly say leadership is accepting responsibility for enabling shared purpose in the face of uncertainty. And we certainly have had quite a bit of that in the last 18 months. And I think continuing to ask questions, challenge assumptions, challenge the status quo, and use data to drive towards where interventions can make the most difference, but do it with empathy and humility and learning is, I think, going to help us be successful. And focus on the fundamentals, always coming back to the work that you've led, Dr. Moy and Dr. Simpson and others in the quality sphere, that quality and equity are two sides of the same coin, and that we can't get to a high quality system without driving forward equity. And I look forward to working with the VA and other partners to do that.
Thank you. Lisa, your thoughts about moving ahead?
Sure. So back in November, we published our framework, which characterizes, how we're approaching this. And we work a lot with the VA on a number of different programs, as Dr. Moy knows, but our members are also in the civilian space. And so the 3 dimensions of our framework, I'll be very quick because of the time, are lead, partner, and influence. And so lead is really, as you mentioned, Jay, what are we doing internally? And we've been working very much looking at sort of an audit of all of our policies and processes internally so that we can really lead with confidence that we're doing the hard work of equity within our organization and looking to eliminate any unintended policies or processes that are discriminatory in any way. So that's the lead. Then the partner is very much, we have organizational partners. The VA is one of them. We have organizations around the country who are looking to us for help with particularly how do we nurture the careers of investigators of color, a more diverse group of investigators from all kinds of different lived experience and every combination thereof. And there are lots of different resources they've talked to us about developing together. So working on that innovation space as partners to move us together and also elevate. We don't give good housekeeping seals of approval, but we can showcase people who are really making measurable progress. And then final, the influence, let's not forget the point that was raised by somebody earlier, the importance of policies. So I think it was Jay mentioned redlining. Well, we still have policies that disadvantage certain groups in who gets funded, what kinds of research gets funded. So we're working on that advocacy side as well.
Yeah, another basic point I'll make is I think we learned through the pandemic that there's a general lack of awareness around health information, certainly a general lack of information outside of our bubble around health equity. And so our commitment at the Dole Foundation, I'm sure a commitment from each of us in here is to inform, educate, and drive awareness among philanthropists and corporate leaders. I have funders at the Dole Foundation, lots of them, that don't know much about health equity. Not a discredit to their organizations. It's just not something that a lot of companies understand. So investments in research, data, education, and awareness are huge for sustainable, permanent ways to fight health inequities and disparities.
Thanks. And Freddie, do you have any thoughts about any changes you'd make?
I don't know about changes, but certainly MIT's ethos has always been men's and minus, right? So hand in mind. And so that has persevered through what we do. And, even with the MIT Hiking Racism Challenge, we said, learn, create, and implement. And that's, really what drives us is to go from ideation to impact, not just the theory or, the studies behind it, but really getting into that goal. And so I think it starts by continuing these conversations like we're having today. It continues in continued conversations, of course, but really keeping that door open for collaborations, for discussions, and for kind of what Jay had mentioned, really push each other on our respective framework of how we think about health equity issues.
Again, thank you all for participating. I look forward to working with all of you because I heard your promise to work with the VA, right? So hopefully together we can solve this problem. Thank you.
Thanks, Ernie.